A, and again, there was no variant detected on the study. And his bone marrow was similar to our first case in that it had an absence of erythropoiesis. However, the other cell lines were preserved in the bone marrow. We did a chromosomal analysis on his blood, and this did show translocation at TQ2223, which gave us a very strong clue to his diagnosis. So he was then transfused during his infant period and started on prednisolone and is now maintaining his hemoglobin on a very low dose of prednisolone, just 1 milligram per day in total, and he's keeping his hemoglobin between 90 and 110 on that. So putting that all together, he has diamond black sand anemia. It's an inherited bone marrow failure syndrome, and it's a ribosomopathy. So 50% of the cases are accounted for by a haploinsufficiency of either a large or a small ribosome subunit. They have congenital anomalies that I'll talk about in a moment, and there's also now evolving evidence there's a cancer predisposition for certain types of them, and it's still unknown which ones are going to have more of the risk of cancer than the others. There's a classical versus a non-classical presentation, the classical being they need macrocytic anemia, resiculocytopenia, normal neutrophils and platelets, and be less than 1 year of age. So talking about those congenital abnormalities, the most common ones are the craniofacial and with the microcephaly and the hypertelorism, although the most one I think is the triphalangeal thumb. That's not one you would miss. So it just looks like they have 5 fingers. And this is a picture of a little girl with it, just demonstrating that hypertelorism that our patient had as well. But they can also have kidney abnormalities, cardiac malformations, and ophthalmic problems as well. Only 33% of them on average do have those congenital anomalies, the rest do not. So in terms of investigating a potential TEC or a DBA, we do an FBE and a red 6 count, hemoglobin F, and this red cell deaminase test needs to be done prior to transfusion, otherwise the testing is thrown off before then. The bone marrow we talked about, and the karyotype, there are 9 known DBA genes that are associated with it. It does have an autosomal dominant inheritance pattern with variable penetrance and expressivity. So he had the one that is 2% of cases, the 10q2223. Talking about the classical versus non-classical, it seems, looking at our RCH experience, it's much more common for them to be non-classical DBAs than it is for them to be classical, and that can pose quite a diagnostic conundrum during that time. So I just wanted to show the major and minor supporting criteria that you can have. The classical, you need to meet all 4. You can have, if you have the gene mutation, you can then be described as a sporadic DBA and not have all of the diagnostic features. And you can have a mixture of major and minor and still end up with it. So the non-classical ones, in the literature, they can present sort of in any number of different ways. The necessity of the diagnosis needs to be more important now as we think these children may then have a risk of cancer going forward. So if they're asymptomatic from an anemia point of view, it might still be important to identify them for a risk evaluation down the track. And this is the 2 papers that we're talking about, looking at further into more genes at DBA. The first one is just talking about a sibling pair that did not have, that were actually red cell ADA negative, so at a normal level, but had all the other features of diamond black sand anemia, and found to have the same mutation in GATA1, which is involved in erythroid progenitors, so it has a possible biological plausibility. And then the second paper talking about how 2 young patients, one was 5 and one was 17, who were reclassified to being 5q minus syndrome rather than DBA as they were first labelled. And that just highlights that although this is an adult diagnosis more commonly, that we should think about it in the paediatric population as well. As I talked about, only 10% of ours were classical and the remainder were sporadic and non-classical, and that's why we've set up the Melbourne Congenital Blood Disorders Alliance, where Monash and the Royal Children's will hopefully facilitate a standardisation of diagnosis and treatment across the 2 centres, because it's quite a rare diagnosis, to help maybe get our numbers up and to do more gene testing from within, and as well as to hopefully make it more standard across both centres. this is just a slide comparing the two, so they can overlap quite a bit. The thing I just wanted to highlight is that depending on when you catch a transient erythroblastopenia of childhood, their hemoglobin F may be elevated if they're in the recovery period, which is probably why our first case did have an elevated hemoglobin F. But the big thing is that the red cell ADA testing and the gene testing, that's going to help a lot. And that is all. Is there any questions? Okay. Yes. Yes. Actually, no, we didn't. After they had the chromosome test, he didn't get one.
And the second part, my question would be, the LDH that all over in both of those, did you have an explanation for us?
I will pass that to my consultants. I have an understanding that children can do this in times of stress, but I think there's not. I don't think there was a pathological reason for it.
And someone else ordered a job. I would never have ordered a test on either of the children. I don't think it LDA is particularly helpful in times where there's down. So,
particularly at that level, I think it's in the south.
the first case had a bone marrow refinement, which is often well done in children. So what was the reason for that?
I think because at the time, having the hemoglobin electrophoresis showing a raised hemoglobin F, there was concern that she might have been a diamond black fan rather than a TEC, I think. That was the reason behind it. But
where she was visited anti-constantly and then went to the and then she got a
Sometimes got a bit lost with the 5Q abnormality.
Yeah.
How frequent is it in DBA? And
not
when you did this refined biopsy, did it have those big karyotypes which look like 5Q minus syndrome?
I'm not sure if they saw that on those two patients, but it's not common at all. I think it's very rare, less than 1%. But I think it's when you have a non-classical DBA, something else to think about as another possibility.
So presumably you can tell us why a response still.
Yes. Yep. I do not know that answer.
But you said it was elevated, but it was for 3 months.
Yes.
That's not elevated.
Yep, I agree. I agree. That test was actually done when she was 6 months old, and I couldn't find the one when she was 3 months old. So, good spotting. Sorry about that. I'm going to shut up.
Why the ribosomopathy has such a explanation?
I think like very clinically we know a little bit, we don't know much, and then what more.
I think back to two questions. One question about the marrow. I think there's 2 ways you can approach these. If they've got multiple cytopenias down, then it's not unreasonable to do a marrow to exclude something else. But often they present with just red cells down, and you can make an argument not to do a marrow because if it's TEC and they're going to recover, then they don't need a marrow. And if it's diamond black fan, then they're not going to recover, and you'll get around to doing a marrow eventually. So I think that's something to be considered in the early phase. And if the ADA is not, agnostic, then often you're a little bit unsure as to which one it is, and it's essentially time that gives you the diagnosis. The problem with putting them on steroids is that most of them will respond, But if you withdraw the steroids too early, then you can lose them and then you can't recapture them again. So once you start one of these kids on steroids, they're on it for a long time. And they come down to these tricky little doses, like a 1 milligram, and it's hard to imagine how that physiologically does anything. But parents come in and see you and tell you they stopped giving them, and now the hemoglobin 50 again, and you put them back on steroids, and sometimes you want to leave them on steroids for a long time. So I think part of our dilemma is always not misdiagnose a PEC and start them on steroids, because the PEC is going to get better spontaneously, and you think it's the steroids that have made them better, and now you're going to leave them on steroids for 3-5 years. Whereas, if you just hold off on the steroids, give them a few transfusions, and they get better, well, they'll probably have PEC. So I think often at a diagnostic and an early treatment level, it can, for the atypical ones, be a difficult diagnosis, and you just need to be patient in how you actually proceed.
All right, thank you, Sally. I apologise for the croaky voice. I'm going to talk a little bit more about TEC and diamond black fan, about contrasting the two. So in terms of red cell aplasias, we've got the inherited ones, so diamond black fan, anemia, Pearson syndrome, and some of the other inherited bone marrow failure syndromes, such as Fanconi. We've also got the acquired red cell aplasia, the primary form in terms of TEC, and also the secondary causes. So more commonly in adults, we would see instances of thymoma causing red cell aplasia, hematological and oncological malignancies such as leukemia or lymphoma. Infections are well known to cause red cell aplasia, including EBV, CMV, parvovirus, HIV, and hepatitis. Medications, drugs, and various chemicals, and the connective tissue disorders and autoimmune disorders are also known to be associated with a red cell aplasia. Pregnancy, renal failure, and nutritional deficiency. So TEC, described as a distinct entity in 1970. I'm bringing your attention to this. This is one of the first reports by Lovrick, published in the Australasian Annals of Medicine. I've been trying to get hold of this original article, but am struggling because it's in the rare journals out in a couple of the libraries. So if anyone has a copy of this, I'd love to see this original article. I understand there were 4 cases presented in this one. So TEC, so it tends to be healthy young children. They're usually 6 months to 4 years, and it's a temporary cessation of erythrocyte production. And it may well be subclinical in many cases, and we never pick it up. And children make a spontaneous recovery. The full blood count is typically normochromic, normocytic, and the hemoglobin is generally between about 60 and 80. There may have been a previously documented normal hemoglobin, and the MCV is usually normal. In our case, the MCV was reduced, which brings up the question about whether there may be concurrent iron deficiency or underlying hemoglobinopathy. Children are usually reticulocytopenic, and extensive evaluation is not usually needed. The MCV is normal if there's no signs of another red cell disorder, no signs of spherocytes or fragments or other things that need kind of further evaluation, and if there's no signs of dysmorphic features. So the etiology, as Sally said, is unknown. There's not been one single causative agent identified, but there's many possible causes. There have been a number of case reports where they've theorised that, they've speculated or reported that echovirus, HHV6, parvovirus have been associated. There's been reports of inhibitors against the erythropoiesis cells and cell-mediated suppression and a genetic predisposition as well. So there's been a few published reports about affected siblings and twins. And I guess the questions raised, is this the same environmental factor or an undiagnosed genetic disease? And Gustafsson in 2002 performed sequence analysis of all the exons in the RPS19 gene in 7 TEC sibling pairs. And the linkage analysis supported allelism for TEC and DBA at their RPS19 gene locus.